Tomosynthesis imaging systems use data acquired in a manner very similar to conventional linear tomography. During the acquisition, the X-ray tube moves in one direction as the detector is moving in the other direction. Unlike linear tomography, the acquired data is reconstructed so that layers at different layer heights are simultaneously reconstructed.
X-ray, we're looking at a lot of things in a longitudinal aspect, but with tomosynthesis, we found that the longitudinal aspect was a good way to start, but after some experimenting and some research, we found that if we think out of the box a little bit and start looking at it in a transverse manner, we were able to acquire much better images.
The tomosynthesis images are able to remove the tissues above and below each layer using a mathematical process similar to a computed tomography. This produces CT-like images that can be reconstructed at closely spaced intervals and reviewed by a physician, much like a conventional CT study would be reviewed.
The digital tomosynthesis tomography is really no different from what we used to do with the hypocycloidal spiral movement with the tomogram. Those systems disappeared and were replaced by CT, and we always noticed that, even with the multi-detector CT, that there was always a certain loss of detail. Now, that loss of detail seems to be very compensated with the tomosynthesis. We noticed that the tomosynthesis actually has a detail unrivaled so far in the computed reconstruction. I don't think CT can live up to what the tomosynthesis has been showing to us.
With the tube scanning across the bony part transversely, the detail was enhanced greatly. The post-processing demonstrated some clinical findings that we were just astounded with once we started to think a little bit against the technical thinking of a radiographer. We have certain protocols in X-ray that we do. The Grashy shoulder, we turn it a certain way. The femur, we turn it a certain way. The hip, we do certain things with. And what we found was that if we modified those positions somewhat, we were able to get much better enhancement and much better detail. A lot of our patients come to us because they're just suffering from some pain that they're not sure why. MRIs are inconclusive. Basic radiographs have been inconclusive. Some are coming here for trauma. Some are coming here for pathologic reasons. So history to us dictates, in large part, the positioning that we'll use. We will try to either get the transverse position or the longitudinal position. In any case, every patient dictates to us more so than we dictate to them based on what their history is.